got 57 medical colleges. 50% of them have got postgraduate students. I think it will be a great job on our responsibility to see that such eminent speakers like you are invited to this forum. And today you are our guest and the chief guest also. And madam, I am very happy that you have selected a topic which is very, very important, sepsis. You know, if you go back to the history of the sepsis, the biggest problem we obstetricians have faced is sepsis. Quite a good number of patients used to die. That is before the advent of the antibiotics, before the advent of sterilization. I think it was very, very high, even to an extent of 50%. The sepsis has been brought down a lot. Earlier in my career as a faculty in one of the biggest medical colleges of Karnataka, that is Karnataka Institute of Medical Science, we used to get so many sepsis cases in such a bad position. In spite of doing everything, we used to lose the patients. But today, the sepsis has been controlled a lot. Lot of research has occurred, a lot of advancement has occurred. But definitely, when we allow a patient to go to severe sepsis, again, the mortality may not be the mortality, but morbidity is the worst thing which you can see lifelong. I think Madam is going to highlight on these aspects, and I request our chairman, Dr. Murli, who is instrumental in bringing you to this forum, to introduce you, Madam. Dr. Murli.
Arun, can you put up the slide? It's my great privilege and honor to have you here, Dr. Sareena, who is epitome of academics, and her annual PG focus program is such a popular program, and I have been fortunate to be part of it for last so many years. And whenever I go there, I get extra energy because the hall is full of PGs who would sit from morning 8 o'clock till 5 o'clock in the evening, or sometimes more than that. And year after year, it is only increasing in number. That speaks volumes about her interest in academics and interest for the cause of obstetrics and gynecology. She is the professor and head of Department of Jubilee Mission Medical College and Hospital. And she has actually won so many gold medals, and the eminent being A.L. Mudaliar Gold Medal in MD from Madurai Kamakshi University. Her field of interest, high-risk obstetrics and gynecology. Obviously, the topic she has chosen belongs to the high-risk obstetrics, that is severe sepsis. She also is interested in plastic work in gynecology, laparoscopic surgery, and of course, teaching. Her achievements: she has been a postgraduate teacher since 1994, presented and published several papers, addressed several obstetrics and gynecology conferences all over Kerala and India, organized several workshops in vaginal surgery, ultrasound, and endoscopy, organized several conferences, the prominent being the AICOG that was held in Kochi. And that's the time actually I was introduced to her, and ever since we have been associated very closely in all academic programs of Kerala as well as Karnataka. She has written chapters in undergraduate and postgraduate textbooks. She has won awards like JCA Professional Excellence Award, IMA Best Doctor Award, Times of India Economic Times Award for the Most Inspiring Doctor, and Most Inspiring Doctor Award by Chamber of Commerce, Chairman, Board of Studies, UG Clinical, Kerala University, Health Sciences. She's also in the board of Confidential Review of Maternal Deaths, which is a unique program of Kerala started by Dr. Paili, and she's one of the very pivotal members there. And that's how Kerala has been able to bring down the maternal mortality. All of us know, apart from postpartum hemorrhage, severe preeclampsia, eclampsia, sepsis is one of the biggest killers of all the mothers. In fact, in the near miss audit that we did in Manipal, somehow in Manipal, we have been able to conquer, in a way, the deaths due to PPH and eclampsia, but somehow the deaths due to sepsis is still not under control. This is a tragedy because we think that antibiotics are there and we should be able to tackle that. The problem is the initial stages, if we don't recognize them, no antibiotics will work towards the end. It's only we'll be treating the pulse and BP of the patient with ICU management. So I request Dr. Sareena to enlighten us how exactly we are supposed to tackle them right from the beginning until the end so as to prevent deaths due to sepsis. Over to you, Dr. Sareena.
Thank you, sir. Good evening, Dr. Hiramat, Dr. Bharati, and my very dear friend, whom as he said rightly, we have known from the day of AICOG in Cochin, a real academician, and I'm not surprised that he has started such a wonderful program for you all in the form of KCOG. Actually, I was just going through that thing of Karnataka College. It sounds so good. It sounds so good. It's like seeing the ICOG and the RCOG, etc. It sounds so good. Today, we are going to talk on a very, very important topic of obstetric sepsis. How do we prevent it and manage it? This is a topic very close to my heart. Do you know why? Because I find this is one thing that we have no control over. Absolutely no control. It takes totally out of your hands. And so I realized that the best form of management of sepsis is to prevent it.
Madam, can you make a slideshow?
Yeah, it is slideshow.
Not yet. I can see still the slide sorter on the left-hand side.
But,
just press enable editing up and then you'll be able to make slideshow, I think.
Is it? I don't know. I made a slideshow. Let me say again.
Okay.
Kiran? So now I'll just go through one case just to tell you what exactly we mean by sepsis. Okay, now this was a real case scenario. She's a para 1. She was referred on the post-operative day 7 to us. Following slideshow. So she was actually referred to us on day 7. Okay. And this was how the story went. She had an emergency cesarean on 2/6 at a private hospital outside. On the 4th, that is the 3rd post-operative day, she started spiking fever. She was having 103 temperature. Her CRP was 106. They'd given her, they stepped up their antibiotics, Cesarean, Metrozil, etc. She was having fever on and off. It persisted. Then they did an ultrasound on the 7th, that is 5 days after that. And they saw a focal collection in the pelvis near the anterior abdominal wall and also on the close to the uterus. Her fever persisted in spite, then they escalated it to meropenem. And that's how she landed to us. Okay. She landed to us on 9/6, that was on the 7th post-operative day. Now, when she came to us, the ultrasound on admission showed that the collection had increased. She had lower lobe consolidation. The CECT was suggestive of an infected uterine wound. Okay, the cesarean wound was infected and it had dehiscent, the uterine wound. Okay, and so what we did was on 10/6 we posted for a laparotomy hysterectomy. There was purulent free. There was almost 1 liter of pus in the peritoneal cavity. There was gross bowel distension, adhesions. And in intra-abdominal and pelvic collection, the uterus was subinvoluted, almost 22 weeks size. Imagine 8th post-operative.
Madam, slides are not moving. I think slides, we are in the first slide only.
Yeah, because I think the slideshow is not been enabled, madam.
Okay.
Unless slideshow is enabled.
Okay. Just a minute. Kiran.
I think you are getting one yellow line there. That's called enable editing. You have to press that. After that, you will be able to do the slideshow.
Okay.
On top, madam. On top.
On top.
On top. Yeah. There's a yellow line.
Yellow line. In between.
Yeah. There you are seeing that.
It is center.
Editing. Now okay. Now reshare.
Reshare.
Yeah. This next slide. Okay. Now
Now slides now slides are not seen. You
Yeah.
have to reshare. You have stopped sharing.
You have to reshare now.
Yeah. You have stopped sharing by mistake.
Sure.
Yeah, and now press slide show at the bottom there.
Okay. Now is it okay?
Now it is correct. Now it is
Yes,
correct.
ma'am. Yes.
Thank you, sir. So then what happened was we did a scan, and the scan, when we opened up the abdomen, we saw that 22 weeks uterus, which was a complete wound, dehiscence of the uterine wound. There was pus filling the uterine cavity, and also evidence of early necrotizing fasciitis of the rectal sheath. So what did we do? We did a hysterectomy on her. And then post-operatively, after we had done that, also third day, she again had a hematoma. We aspirated that and she was discharged. So all went well, but remember what all we have done? We did a laparotomy and we did a hysterectomy. We removed the source of infection. Probably that was what saved her. Okay. Now, what do you mean by surgical site infection? Surgical site SSIs, as we often know, is defined as an infection of the superficial or the deep skin incision or of an organ or space which occurs within 30 days after any surgery. So anything we call it as an SSI, that is an ordinary infection. It's only an infection. It is not graded to the level of sepsis. Okay. But if there is an implant, even up to 1 year, we can call it as SSI. Okay. Now, I'm just quickly taking you all through. When you say superficial incisional SSI, it means skin and subcutaneous tissue infection. Okay. So we can write in our notes superficial SSI. When I use the word deep, it means there is a fascia and the muscle has been involved. Okay. And when I say organ space SSI, that means it's gone to peritoneal cavity, organs have been involved. Okay. So this is basically how we classify SSI. Now there is another thing which you all should know. It's called the surgical wound classification. Now, class 1 is a clean wound. Now, whenever you give prophylactic antibiotics, etc., it is for this kind of planned cases in which we do. And you find that, it's an uninfected wound, there's no inflammation, we have not opened up any respiratory, elementary, genital, and there's no opening up of any of these things. But when we do a hysterectomy, it comes under class 2 surgical wound classification, which is a clean contaminated, CC. That is, we have opened, purposefully we have opened into, now anything, whether we open into respiratory, elementary, genital, that's what we have opened into the genital, okay, we have opened the vagina. Or the urinary tract are entered under controlled conditions and without unusual contamination. There's not much of contamination on a hysterectomy. When you use the word class 3 contaminated, it means an open, fresh, like an accidental wound. Okay. You had an accident and then, but when you say a dirty infected wound, it's exactly like something which we had today. We opened the abdomen full of pus. And when you have perforated intestines and things like that. Okay. So then, and you've got devitalized tissue, like which happened in our case also. So that comes under dirty infected wound. So that is one classification. Now, how can we prevent it? They say that nasal decolonization with mupirocin in patients prone for MRS. I'll tell you more about it later. Okay. They say that it's good to have a pre-bath with 4% chlorhexidine. Hair removal with electronic clippers, not shaving, but a single-use head. Okay, don't keep on sharing it with many people. A single dose of IV cefazolin, 2 grams with induction of anesthesia. That is within 1 hour of the incision. We have got to give 2 grams of cefazolin. We normally redose it if the surgery is prolonged for more than 3 hours, or if you've had a lot of blood loss of more than 1,500 ml. Skin decontamination. That is now when we are painting. Okay, we should either use 4% chlorhexidine or 10% povidone iodine. And it should be in contact for 3 minutes before surgery. And this will reduce the load of resident skin flora, subsequent reduction in incidence of SSIs. So this is one gross form of prevention. Now, why did I tell you this 10%, etc.? Now, in our hospital, I remember there was a time when the nuns would pour a lot of water into the iodine. Don't dilute the iodine, okay? Let the povidone be 10%. If it is chlorhexidine, let it be 4%, okay? Now, we all would have heard about this big thing called Surviving Sepsis campaign. It is called SSCs. Earlier on, it used to be the 3 hour and 6 hours bundle, but now we call it the 1 hour bundle. Whenever at the same time, the group together to be done at the same time. Let's see what it is. So earlier on, we would say 3 hours and 6 hours, but now we say within the first hour, get going. Let's see what it is. So severe sepsis actually means it's accompanied by 2 or more vital organ dysfunction. That's when we call it MODS, multi-organ dysfunction. So you should have 2 or more vital organ dysfunction. Now, for example, don't you see a patient with severe sepsis has got ARDS? That means the lungs are involved. Now, what is another organ? Kidney. You can have an acute, you can have sometimes total renal shutdown, isn't it? It could be acute tubular necrosis or cortical necrosis. Sometimes we have persistent hypotension. Then the cardiovascular system is involved. When you've got a patient who's little disoriented with severe sepsis, etc., we say she's gone for a metabolic encephalopathy. Even severe sepsis can go for a DIC. Then many times, in fact, we have got now a very bad case of paralytic ileus and sepsis. Okay. So then the GIT is involved. When the liver is involved, you can have acute hepatitis, and the adrenal glands, you can have acute adrenal insufficiency. So when you try to see, any 2 of these organs are involved. Maybe she's got an ARDS and a kidney shutdown. Then she is in MODS, severe sepsis with MODS. Okay. Now I will tell you a few things about the various terminologies. Now we have all heard about SIRS. There are 5 components in SIRS. That is systemic inflammatory response syndrome. Okay. That is, whenever there is an insult in the form of an infection, the body reacts. And how does it react? Either you can have temperature. You can have a temperature more than 100.4 degrees, is considered positive, or even if hypothermia is also bad. Okay, that is less than 96.8. When she's got a tachypnea, in fact, if you ask me, when I go for post-operative rounds, if I see a subtle tachypnea, beware, it may be the evidence of early sepsis. When you've got a TAC more than 90, heart rate of more than 90, then the WBC count, very, very, very important. This is, you must ask for the WBC count because, and this is something which you can ask on a daily basis to monitor your patient with sepsis. You'll know whether she's improving or deteriorating. So if the WBC count is more than 12,000, it's bad. If it is less, it is corresponding to leukopenia, it's also bad. Or she's got more than 10% band forms, it's also bad. Okay. Then of course the PCO2, I'll tell you more about it later. It's less than 32. So in this 5 SIRS, if you've got 2, if you've got temperature and increased tachypnea, or you've got a tachycardia and a tachypnea, but in the presence of sepsis, but in the presence of infection, then I use sepsis. Do you understand? So look at my second column, which I use sepsis. I've got 2 SIRS. Out of the 5, I've got 2. Got a confirmed, maybe I've got a wound infection or foul smelling discharge, PV, etc. Then I call it sepsis. When do I say severe sepsis? Now you all know signs of end organ damage, and I told you severe sepsis, and when you say MODS, etc., it is when you've got more than 2 organ damage. And then you've got hypotension and lactate. Very, very important. Please remember this word lactate now and always in sepsis. I will tell you more about it as we go by. Then you've got septic shock. Do you know when I say septic shock? When the patient has got severe sepsis and intractable persistent hypotension. If there is a persistent intractable hypotension, then I use the word, this patient is in septic shock. Okay. So now you all know, you know, when I say SIRS, to call use the word sepsis. Otherwise, I use the word only infection. There is wound infection, SSI, but that's all. But to use a severe sepsis, and I told you got end organ damage and hypotension, and lactate is also raised. And septic shock means there is persistent hypotension. Okay. Then by the time you normally have an end organ damage and you've got lactate raised. Now we all have heard about the SOFA. SOFA is nothing but sequential organ failure assessment score. If you have got acute changes in more than 2, it's bad. It's bad. Okay. Now you look at, this is the SOFA, which is sequential organ failure assessment score. The European Society of Intensive Care Medicine has given us this. Now you look at the first column and you look at the last. See, when it is very severe, when it is respiration, when you've got a PaO2, FiO2, remember that should be good. If it is more than 400, your score is 0. But if it falls less than 100, in the presence of COVID, we were all checking this PaO2 and divided by FiO2. If it is less than 100, it's bad. It's bad. Okay. You already got a score of 4. If the coagulation, look at the platelets, less than 20,000, bad. Liver bilirubin, you look at the bilirubin alone, it's enough. If you've got more than 12 bilirubin, it's bad. You've got evidence of hepatitis. Cardiovascular hypertension, when she requires a dopamine, and then comes first, okay? And dopamine. So that means she's in hypotension and she requires that. CNS, when your Glasgow coma scale is less, it should be 15, right? If it is 15, there is no problem. If it falls to less than 6, that means she's disoriented, she's got a lot of issues. Then it is less than 6, then already the score goes up to 4. And of course, renal creatinine, if it is more than 5, or the urine output is less than 224 hours. So when you look at all these things, look at the last column, all these shows you that there is an end organ failure. End organ is, I told you in the beginning, what the liver, the kidney, the lungs, etc., etc. So now this is so elaborate the scoring. So we've got something called the quick SOFA, Q SOFA. Now everybody calls it the Q SOFA. Q SOFA is a quick SOFA score. Just remember these three. Systolic BP of less than 100. It should be less than 100, okay? Then that is one score. Altered mental status. If the GCS, I told you 15 is normal, less than 13 is still bad. Like she shows a disorientation, it's bad. And I told you the tachypnea. Remember, I told you respiratory rate. When you find that the patient has got some fever and tachypnea, etc., remember. So out of these three, a score of 2 suggests a greater risk of a poor outcome. So this is the quick SOFA score. You check the blood pressure, the sensorium, and the respiratory rate. So systolic less than 100, a GCS less than 13, and a respiratory rate more than 22. She's tachypneic, it's bad. Any 2 of these is there, it is severe sepsis and it's bad. Now, I wanted to tell you, now we are always updating. SIRS took us, which is emerging. That's why again I told you about it. SOFA also was 2 years, they're all talking about the SOFA, the quick SOFA scoring. But this is the latest score, okay? The simplified acute physiology scoring, it's called the SAPS-2. Now, this is what we follow. You see the score which I have taken from our hospital thing. In this, they have taken lot of vitals, some of the investigations, and some of the non-modifiable factors like age. If you look at the age of more than 80, already you go into a score of more than 18. Chronic disease, supposing she's got a metastatic cancer, age, see already she's grossly immunocompromised, 17, the score is 17. The type of admission, if it's an emergency surgery, then already the score is 8. You'll have to add up everything, okay? Then they have given all the parameters. I told you the heart rate, the systolic. You can take a picture of this if you want a screenshot. This is from our critical care, okay? They follow. So they follow this. All this should be assessed within the first 24 hours of admission into the critical care unit. Okay, so you look at the heart rate, systolic BP, temperature, the PS ratio, which I already told you, I told you just now, and the urea count, check the electrolytes. You must check the bicarb, the bilirubin, and the GCS. All you have to investigate the patient. Only then you will know the extent of end organ damage. So all, and look at the SAP scoring. If it is a score 29, 10% mortality, but if the score is 77, see, each score is put in individual, everything is an individual score. You see, in the brackets, you'll see 4, 2, 3, all that indicates that's a score for that. So this, you've got to check it out. You must have it in your critical care room. And then within the first 24 hours, you put this and you'll be able to assess the mortality which you're going to have in your hands because of severe sepsis. So please take this on. This is the latest, in which you incorporate the vitals as well as the investigations and non-modifiable factors put into one nutshell to assess your prognosis. So basically, isn't this what we should be asking for a complete blood count? Do their LFT, do their RFT, do the electrolytes. Do the electrolytes, very, very important. Do the culture before you start. Let it be from the wound. If you want, you can take a blood culture, you can take a high vaginal swab, depending on where your sepsis source is. Do you understand? If it's a wound, abdominal wound sepsis, then you check from the abdominal wound. Take a good, if you've got a drain, you take a bit of the drain, cut the drain and take it out, and you're taking it out. Coagulation study should be done in ABG, and you're all about ABG after this. Okay? You'll find that all these are the basic investigations we should do in a case of severe sepsis. Not for an ordinary wound infection, severe sepsis. Now, you already know what severe sepsis is. Now, identify the source. It can be an obstetric or a non. The case which I presented, the source of infection was actually abdominal wound, the uterine wound, it was full of pus, you remember? So I removed it. Another time you can get urosepsis. Many times we get urosepsis. From the catheter it starts and then later goes into pyelonephritis and so on. Most common risk factor is cesarean. Haven't we seen many times our patients have had a cesarean? Sometimes it's retained products of conception. Please evacuate if need be. Pus anywhere, the old dictum, let it out. And remember this, the last line, but let it be through the most non-invasive route. Now we have done pus. You do it in whichever way you want. Supposing it's a tubo-ovarian abscess, then you can remove by a laparoscopy, remove that mass. Tubo-ovarian mass can be removed laparoscopically. So let it be by the most non-invasive route, but remove the source of infection. Otherwise, your patient will never improve, how much ever you give the antibiotics. Now I will take you through the main management. First is the fluid management. You'll have to give crystalloids. When you say crystalloids, it is either normal saline or ringer lactate. Don't go for dextrose, okay? Now, how do you give it? You'll have to give large amount of fluids. Maintain the CVP between 8 and 10. So put a CVP line and then you'll know how much of fluids to give. They say within the first hour of 1,000 ml and then 500 ml within 30 minutes. And then you see the CVP and then you decide. If you do not have a central line, look at your BP and urine output and let that be the surrogate markers. So you know how much of fluids to give. If after giving fluids, the hypotension does not come down, if she's going for a septic shock, you remember I told you that if it's refractory hypotension after adequate fluid challenge, you'll have to start on vasopressors, and the most important is NORAD. NORAD is most important in sepsis, start NORAD, then maybe sometimes you may have to add on dobutamine, dopamine, etc. Depending on where the cardiovascular system is involved, we give dobutamine and so on. Okay, so fluids is the first, and then after replenishment, only should you go, if the BP is still low, then you give the vasopressors. Then ventilation, let it be any form. What is our aim? We all have learned during the COVID times. What we have to do in ventilation is keep the SpO2 at 95 and over. So what do we say? More than 94. More than 94 is 95. Simple. Let it be through nasal prongs or mask, or whether you have got non-breathing mask, or you've got whatever be it, but your oxygen levels should come up to 95 and over. That means it's more than 94. Okay. But if you find it is still not picking up, now see, this man has got an NIV. If it is still not picking up, then you'll have to go in for invasive ventilation. Okay. Invasive ventilation. Until this stage, it is non-invasive. Okay. So you'll have to see the oxygen saturation more than 95. If there is bleeding, ongoing bleeding, keep the hemoglobin. Don't make it very prim and proper at 12. Even 7 to 9, hemoglobin is fine. So build up the hemoglobin. Even if you bring it up to 9, it's just fine. So give a blood and blood products depending on what you've got. Then this is the most important thing I want you all to remember. The important sepsis markers are CRP, okay? The C-reactive protein. The lactate, I kept on telling you all about lactate because serum lactate is a marker of tissue hypoxia, and curing can be used as a prognosticating indicator. Cutoff is 4. Remember the serum lactate you must ask in severe sepsis, and if it is more than 4. In fact, they ask us to start acting when it is more than 2. So it shows you the importance of lactate because it tells you that there is tissue hypoxia. And then CRP, yes, it's a glorified thing, but if you're able, we do the CRP, so we do the complete count, we do the CRP, we do the lactate, and I'll tell you a word about procalcitonin. I'll tell you what the importance. We always do the procalcitonin in our hospital. You might call it a glorified CRP, but it is very useful for prognosticating. You have a patient with cesarean, and on the 4th, you go and you find suddenly there is hypotension, and you don't find any source for the bleeding, and she's hypotensive. Then maybe, but I'm not able to locate the sepsis. Do the procalcitonin. If it should be less than 0.25. If the calcitonin is raised, it is sepsis. So please, these 4 investments, bleed blood count, WBCs, etc. CRP is important. It is so important. I told you more than 2 itself. The SOFA thing, they've asked us to act on it. And the procalcitonin, when you're groping in the dark, not knowing why is this patient in shock? Is it due to sepsis? Procalcitonin will tell you if sepsis or not. Now, if there is procalcitonin is normal, that means the hypotension is not due to sepsis. I hope I've made myself very clear. Okay. So the management of sepsis-based guidance, the warm fluid replacement, I already told you, Renal lactate or normal saline, avoid 5% dextrose. High flow oxygen, maintain it more than 95, meaning 95 and over. You should have a good glycemia. In very severe sepsis, you'll find that the blood sugars drop. So then you will have to give, maybe you'll have to give 5% dextrose at that time. Keep the sugars between 140 and 160 range, okay? You'll have to give, often haven't you noticed when we are writing the prescription, you must write a Pantocid or a Rabiprazole or something. So stress ulcer management is very important. DVT prophylaxis is very, very important. Don't forget that, okay? So she's under complete bed rest in the ICU. You'll have to give her the DVT prophylaxis. Now, central and enteral nutritional support. Now, sometimes we give them total parental nutrition. It is called the TPN. You see the most of our surgeons, etc., in the critical care unit. So you will have to see that nutrition. It is hydration and nutrition. Please remember two things. You have to maintain the nutrition. The patient is going to take so many days to recover. Ventilatory strategies. Let your anesthetic or the critical care team manage that. Okay. Blood component therapy. You check out. You can check out. You can, if you think it's a DIC, do a ROTEM or a TEG. It's very, very important. Renal replacement therapy when needed. Then comes the ABG. ABG is so important. I can't tell you the importance of ABG, and I will tell you all, because I've got so much of time on my hands, I will tell you all how to read an ABG. Okay, so that will reveal what is acidosis, hypoxemia, hypocapnia. So I'll tell you, and sepsis is one condition you must ask for ABG. Peripheral blood culture. I told you, wherever you got infection, it's a urine, or whether it's a swab from the vagina or sputum, if you think it is cough and things. Intravascular catheters, yes, you may have a central line, maybe that got infected, wound infection, wherever it is, take a culture from there. Please take it. Imaging, don't sacrifice any imaging. If you've got an ultrasound, it's enough, it's okay. If you think a chest radiography is required, your CT, maybe it's a perforated gut, do a CT contrast, okay? Check out the creatinine and do the contrast. Then you can, then I told you the Procalcitonin. So these are all things which you must do for sepsis. Stabilize after initial resuscitation, prompt referral. If you think you do not have all these facilities, please take her off to a higher center. For patients in ICU, in mod, septic shock, etc., they may require CPR and all that. And perimortem, supposing that the patient, for example, it is a perforated gallbladder abscess. Okay. Then what will you have to do? You have patient is in peritonitis, etc. Open up, immediately open up, take the baby out, and then do the rest of your resuscitation. So anytime when you find there's intractable sepsis, and if it is more than 26 weeks, it helps you resuscitate the mother. Okay. Then, of course, we give all the, I will tell you a little bit about antibiotics also at the end of this. We often give them a gram negative, a gram positive, and an anaerobic coverage, and I'll tell you more about it as we go by. Explosive infection. What did I do? I did a hysterectomy. But suppose you collected pus in the pouch of Douglas, do a colpotomy and drain. Bus, that's enough. If you think it's a localized thing in the tubo-ovarian abscess, do a laparoscopic and remove that, okay? The poor outcome is delay in identification. If you sit on it, not knowing, get somebody else to opine on it. Give a second opinion, a third opinion, it doesn't matter. And initiate antibiotics. Severe metabolic acidosis has got to be corrected. Acute lung injury, ARDS has got to be corrected. Do everything that you have to do. Now, I will just take you through ABG, arterial blood gas. Okay. Now, how do we read the values? And I'll tell you quickly so that in future, when you get an ABG, you'll be able to read it and you'll be able to interpret it. Blood for ABG is collected from an artery. We do any from the vein, right? But this has got to be from an artery. Either it's a radial or it could be your brachial or a femoral. In a heparinized syringe, it should be taken. How do we take it? See, normally say that the pH. I want you to remember just this number, 7, 35, 45. 35 and 45. Remember, that's a pH. 35, don't go to all these minute details. 35, 45, you'll have to remember this. Our normal pH is that. So when you look at that value in that ABG value, if the pH is between this, that means the pH is an expression of the hydrogen ions in the body, and it's very important. So now we all know that when the pH drops, the pH increases, it is alkalosis. All of us know that, right? So if it is less than 7.36, it is acidosis. If it is more than 7.45, it is alkalosis. And so it interferes with cellular functioning and uncorrected will lead to death of the patient if you don't correct the pH. Okay. Now, when to do an ABG? We do an ABG when there is severe sepsis. You must not forget that. We also do when there's hypoxemia in the case of severe hypotension. The pulse oximeter cannot detect. Then you will have to ask for an ABG, assessment of any systemic disorders. How do you do it? Either I told you from the radial, brachial, or femoral. Things we do is a spirit form, a 2 ml syringe with xylocaine, 2 ml heparinized syringe, gauze swab for applying pressure, because after this you must apply it, because it is the arterial that you're punctured, okay, the artery that you're punctured. And this has got to be transported in ice packs if it is more than 5 minutes. If your lab is just next door to your theater, no problem. But if it is going to take a little time, it should be ice packed that contain all around it. Within 5 minutes, it should reach the lab. Explain, and then you do a little wrist extend. Identify the pulse, locally infiltrate. Insert the needle at a maximum pulsation 20 to 30 degrees. Aspirate just 1 ml of arterial blood. And when you take it in your syringe, if there is an air bubble, expel that air. Just push it out. And most importantly, whatever, just cap the syringe. Cap it. Okay? That is, you put that cover over the syringe thing. And then apply pressure over that for 5 to 10 minutes. Now, things to remember is keep everything ready before the puncture. After puncture, don't run for this heparinized syringe. You should have informed the lab, ABG is on its way. Please keep the lab monitor ready. Always expel the air bubble, and I told you, cap the syringe immediately. Always transport in ice packs. Mention the date, time, and the FiO2, because the patient will be on the ventilator. Remember, the FiO2 is the oxygen of the inspired air. Okay. The normal air oxygen pressure is about 21%. You got. Apply pressure post puncture. I told you 5 to 10 minutes. The problem after you do an arterial, either you femoral or the brachial or the radial, I said, you can have a hematoma there. So keep it there tight. You could have vasospasm. So don't keep on doing it. If you do it once, let it be the first shot that you get it. Arterial, you can have a thrombus. Okay. You can also get it infected. So things you should not do, no tunicate. Don't give a tunicate like how you do for the venous collection. Avoid too much of heparin. There's only that much of heparin in the syringe. Avoid filtration, avoid too much of negative pressure, and avoid too many attempts at the same time. You'll have wrong values. Now remember this. I told you 75-45. Okay, 7-35-45. That is the pH. Remember the same thing for PCO2. PCO2 is also 35-45. Very easy to remember. Okay, so 35-45, that should be your PCO2 on that paper which you get, ABG paper. The bicarb, yes, we know university is 24 milliequivalents per liter. Okay, so you remember that's all the values, and you know the entire ABG. 735, 745, 40 millimeters of mercury. That is, again, you take the PCO2 as 35-45. Forget about the 40. And the bicarb, yes, it should be 24. We all know that the bicarb causes acidosis, right? So 45 on a ABG paper, there's no acid-base disorder. Now, I told you some time back, acidosis, when the pH drops, it is acidosis. All of us know that. But that acidosis can be metabolic or respiratory. We all know that. And when the pH increases to more than 45, 745, we know that is alkalosis. It could be metabolic or respiratory. Now, I will just look at my hand, okay? Now, when the pH is reduced, look at the PCO2. See, both have reduced. See, both are in the same direction. Same direction means it's metabolic. So if the pH is reduced, and if you find the PCO2 is also reduced, then you've got pH is reduced, so it is acidosis. Then if the PCO2, it is metabolic acidosis. Got it? Now, if the pH is raised, it's alkalosis. If the PCO2 is also more than 35-45, I told you 40. If both are raised, pH is raised and the PCO2 is also raised, both same direction. This again metabolic alkalosis. Very simple, very, very simple. Have all of you understood? Yes? No. Now I'm going to the respiratory. So there is only two things. There is respiratory. Respiratory, it will move in the opposite direction. Now the pH, look at my thing, the thumb, it has dropped down. That means it is acidosis. pH has dropped, less than 735-45, pH has dropped. But the PCO2 is raised. It's gone in opposite. Expiration, expiration. So this is respiratory. Opposite direction. That is, I look at the pH, then I feel, there is acidosis. Then I look at the PCO2. If the PCO2 is also dropped, then it is metabolic acidosis. But if the PCO2 is increased and pH is low, opposite direction, this is respiratory acidosis. It's acidosis because the pH is down, but the PCO2 is raised, it's moved in the opposite direction. Okay. Now look at this, how my hand has changed. The pH has gone up, that means it's alkalosis. The PCO2 has dropped, again opposite direction. This is respiratory alkalosis. You have learned ABG. You understand? So that is to ABG, right? So you PCO2. So only 735. The PCO2 is no 35, 45. Okay. So you look at just, first of all, with the pH, you must say high. That means it is dropped. Then you look at the PCO2. If the PCO2 is also dropped, this is metabolic acidosis. If the pH has dropped and the PCO2 is increased, it's opposite direction. This is respiratory acidosis. Got it? Now the pH has increased, so I say there is alkalosis, but I don't know if it's respiratory or metabolic. Look at the PCO2. If it is more than 45, both same direction, it's metabolic alkalosis. It is just dropped, but the pH is raised, and this PCO2 has dropped opposite direction, respiratory. That's what I'm going to tell you all. To know if it is metabolic or respiratory, concentrate on the pH and pH bone. If they both move in the same direction, it's metabolic. If they both move in the opposite direction, it's respiratory. I hope I made myself clear. So again, the same thing I'm telling you all. pH has dropped. The PCO2 has also dropped, and this is metabolic. It's acidosis because the pH has dropped, but the PCO2 is also showing a downward direction, so it's metabolic acidosis. The pH has increased, the PCO2 is also increased, it's metabolic alkalosis because it's alkalosis, pH is raised. Now the pH has dropped, so it's acidosis, but the PCO2 is raised, so it's opposite direction, it's respiratory acidosis. pH is increased and the PCO2 has dropped, it's respiratory alkalosis. Now, whenever you see this, there is a compensatory mechanism. Probably when I meet you all next time, I'll tell you this. Always in respiratory disorder, compensation is by the kidneys and by adjusting the HCO3, reabsorption and the proximal tubules. If the metabolic disorders, see whether it's compensated or not, you'll have to look at there's a little more to tell you on that. I want to tell you, but I don't think I'll have the time. If Dr. Muralidhar gives me the time, I'll certainly say it. Then a few tips on antibiotic policy. Now, I told you always we talk about gram-negative. Now, many of us, we do not know, we have forgotten our gram-negative organisms. What are our gram-negative? Remember these 4 organisms. E. coli is gram-negative, Klebsiella is gram-negative, Proteus is gram-negative, Pseudomonas is gram-negative. Remember these 4, don't forget E. coli, Klebsiella, Pseudomonas, and Proteus. So if they say the culture has grown E. coli, it's a gram-negative organism, it is a gram-negative septicemic shock. Do you understand? Gram-positive is the Streptos, Staphylococcus, and Enterococcus, all that is gram-positive. So the Streptos, the Staphylococcus, all that is gram-positive. Do you know why? Whenever you give something, you must take care of the gram-negative and the gram-positive organism. It may be a gram-negative septicemic shock, but there may be gram-positive organisms also. Then you all know the anaerobes, the Peptostreptococcus, the Peptococcus, the Clostridium, and the bacterioids, all anaerobes. Forget all that. You must give an anaerobic coverage wherever you think the vagina is contaminated, the bowels and all that. All those you'll have to think of giving an anaerobic also. So this basic idea, don't forget the gram-negative organisms. Now I will tell you what are the antibiotics we give. Now whenever we give the ampicillin, listen, all that, it all sounds like the penicillins, they are the ones for the gram-positive organisms. Okay, so I told you the Staphylococcus, the Streptococcus and all that, that is a gram-positive. That is why we add one of the penicillins. And many times, haven't you seen, you saw that to decrease the some organisms, they produce a beta-lactamase enzyme. It's very difficult to control that organism. So to these drugs, if you add one of the following, flavulonic acid, for example, amoxicillin, flavulonic acid, better beta-lactam coverage. Piperacillin, azobac, better beta-lactamase coverage. And that is ampicillin, sulbactam. You know, we have got new combinations, ampicillin, sulbactam, cefoperazone, sulbactam. All this will cover the beta-lactamase coverage also. Okay, so remember that these combinations are very good. And many times we give azobac, piperacillin, azobac 4.5 grams 3 times. So what does it do? Lactam coverage also. So that is a very broad spectrum coverage. Do you understand? Cephalosporins. Now, we will not talk about the 2nd generation because we normally don't use the 2nd generation. But all know about the 3rd generation cephalosporins. So, generation is very potent against gram-negative. What is it? I told you E. coli, Klebsiella, Proteus, and Pseudomonas. So it's very good against them. And it has got some gram-positive, but no action against Pseudomonas. So Pseudomonas is one thing, aminoglycosides. So that is why what do? We give a third generation with an aminoglycoside. So we give a cefotaxime, aminoglycoside, what is it, gentamicin or something, or aminoglycoside is the elder brother of gentamicin. Okay, so you can give one of that, and we give a metrogyl. So we give an anaerobic coverage. Cefotaxime we often give. It has also got the same gram-negative coverage also it has got, but same hasn't got much of an action on Pseudomonas. So you'll have to give, along with the cefotaxime, give a gentamicin or amikacin. Cesarean is highly active against Pseudomonas. Cefoperazone, sulbactam, you don't have to add gentamicin because it's also got Pseudomonas coverage. You understand? Then the monobactam, the azithromycin. Please remember, all these drugs are reserved drugs. The carbapenems, not give it because it's available. They're all reserved drugs. Do not use, I've known many institutions in which you all give the large antibiotics for your prophylactic antibiotic. You don't require it. It's like simply drinking water. It has no action at all. Why are you producing resistance in your institution? Every institution should have a very antibiotic policy and do not get antibiotic policy. For example, in our institution, I will tell you what we give. We give for a normal clean hysterectomies, whether it be TLH or vaginal or abdominal, we give only cefazolin. And then if she's got a catheter or something like that, I may add a cifran for 5 days. But I give only one shot of cefazolin. It is nothing but first generation cephalosporin. I do not give a third generation. We are supposed to give third generation in our institution. If you have got giving a third generation, you should have a reason to give it. Do you understand? So don't think by giving a C-tri as your prophylaxis, you will not get infection. Very sadly mistaken. You're extremely sadly mistaken. If you, on your post-operative rounds, if you see the wound is infected, getting red or there's induration, then you add on. It will help you. You're seeing a patient every day. Don't give the high-powered antibiotic. You land in deep trouble. And this may only take home to all of yours. Don't misuse. Keep your antibiotics very safe. We may not have any more antibiotics to come in days to come. We may not have them. Aminoglycosides, keep them for the Pseudomonas, Proteus, Enterobacter, all the E. coli. So it's very good against all the gram-negative organisms, the aminoglycosides. So don't simply give gentamicin. Now, I hope you all know that we give gentamicin 160 milligrams as an OD dose. It's no more divided dose. If you're giving amikacin, we give 75 milligrams OD. But if this has got no action on strepto and all that are gram-positive. Amphi-gentametrozole. Got it? For the milder infections, we give amphi-gentametrozole. Therefore, they can be combined. That's why we always know, supposing there is a chorioamnionitis. Okay, chorioamnionitis is when the pulse rate is more, the patient has got fever, tenderness of the abdomen, foul-smelling discharge, all these things tell then the counts are raised. That is all evidence of chorioamnionitis. Give amphi-gentametrozole, no problem. So giving gram-negative, gram-positive, and anaerobic coverage. So this is the combination. So either you can give gentamicin, piperacillin, sulbactam if it's a higher infection. If you've got an MRSA, MRSA is a methicillin-resistant Staphylococcus aureus, or if you've got a vancomycin-resistant enterococci. Remember, don't go and give your vancomycin for anybody else. Reserve your vancomycin and your lineage only for this MRSA. And believe me, the emergence within hospitals of MRSA is a very worrying trend. So when do you stop your antibiotics? We stop any antibiotic for any sepsis when the fever is 48 hours or when you've completed the course. Don't give for 1 day and 2 days and then stop it. Please do that. Complete your course and then only stop it. And then you can continue it for 7 days, sometimes 9 days. We give it when she's responding and when she's fever-free for 48 hours. There are different manifestations of sepsis. Mild infection. This is only infection. Yeah. Now it is increasing. Parametritis. That means she's got tenderness in the fornices. She's got a fullness, and when you do a scan, they say there's a collection of pus in the pouch of Douglas. She's got peritonitis, which is guarding, rigidity, distension, etc. Septicemia. Bloodstream is called septicemia. And I told you, septic shock is when there is intractable hypertension with severe sepsis. MOD is when there is more than 2 organs damaged. The predisposing factors for sepsis are pregnancy with PROM and PPROM, wrong labor, multiple. Please don't do it. I used to tell my PD, if you want to do a obstetric PV, You must wash your hands and don the gloves and do it under all aseptic conditions. But a gynec PG, even if you do it, PV, even if you do it without a glove, it doesn't matter. Not that you should do it without a glove, because it doesn't really matter. But in obstetric PV, you should wash your hands and then put on the gloves. Reduce the number of pelvic leaks. If one person has done, the other person, let me also, madam, see. Let me also see, madam, about 5 people do the established sepsis. You understand? So traumatic deliveries, you may have to step up your antibiotics, manual removal of placenta because you're going into the uterine cavity, LSCS, PPH, anemia, malnutrition. How do you prevent in your, this is a very important slide and my second last slide. Please remember, see that your patients have got a change of clothes for the labor room. Okay, let them not wear what she has worn from home and come. Let her wear something. Either you've got a white top and a bottom, or you've got some top and a skirt or something like that, but change your clothes. Try a bath before she comes. When she comes in labor, you say in Malayalam, have a bath and come. Labor room to get the status of have to fumigate labor room, but regular cleaning is important. Soap and water cleaning. Whenever if you've got your labor room, you should have washable floors and walls. We have up to 6 feet, you must have tiles in your labor room. Okay, see that you're able to wash them. Soap and water wash is all what you require. Your labor room cots, it can be high funda labor room cots, but see that better to have something which you can wash, steel tops. Don't have the Rexin tops, okay, that you can't wash with soap and water. Mopping the floor after every case. A disinfectant, even your sodium hypochlorite bus, 0.1% bus. Once a week, a labor room wash. The whole labor room should be washed with soap and water. I did not ask you to fog or to fumigate. Regular cleaning of suction tubes. You know, if you look at your suction tube, it would have got about 5 years dirt inside, that blood collected, clotted inside the suction tube. Oxygen mask should be cleaned. Proper hand washing. If you don't wash, your duty is never wash. You should be a role model. Elbow taps, you know, you can't, after washing, you can't do this. You got to have elbow taps. Initial cleaning of all instruments with bleaching powder. Then after that, you must put soap and water. Then only do your disinfectants. Proper cleaning of perineum and abdomen with betadine. Please clean them. And don't take it away with spirit. Let it be there on for 3 minutes, as I told you all. Containing sepsis in your institution. You know, in our institution, I started HICC. That is the Hospital Infection Control Committee. You should have HICC. Incorporate your microbiologist, the surgeon, the gynecologist. Have one person everywhere. See to the cleaning of what I told you so far. Sepsis Prevention Committee to be mooted in every institution. Regular swabs from different parts of the labor room. Take regular swabs at least once a month from the labor room and from the OT. OT you will have to fog. You know, we do the what is the Eco Shield fogging for 20 minutes. Eco Shield is a combination of hydrogen peroxide, silver nitrate. You do that fogging for 20. That is for the OT, not for the labor room. Labor room, it's only soap and water wash. Have a common antibiotic policy. Don't allow one person to be using Citra and you be using ampicillin. Don't do that. You see the culture trend and let your microbiologist tell you what your antibiotic policy should be. At least for a few months, it will be like that. Then she'll say, now, madam, change over from cefazolin to augmentin, she'll tell me. So I go for, now we are using augmentin, that is amoxicillin clavulanic acid, because we have found a little resistance to cefazolin. So change according, but don't go for Citra and Genta. I mean, high powered. Follow all aseptic precaution and insist on your juniors also to follow them. Limit the number of invasive manipulations, including very, very important is good surgical techniques. There are some people who will not wash properly, who will take, you know, one quick wash. No, 5 minutes wash, first wash, surgery scrub. After that, for every subsequent case, 2 minutes wash. 2 minutes is a long time. So friends, thank you so much for your very patient sharing.
Dr. Sareena, it
Yes.
was fantastic. You told about this. Okay, you told about this. But what about this? This means Sareena Gilvaz's talk. When both thumbs are up, that is Dr. Sareena Gilvaz. Yeah. So it was fantastic. And today, actually, it is so clear. And I don't think anybody should have any doubt anymore with regards to alkalosis, whether it is metabolic or respiratory, acidosis, metabolic or respiratory. And certain things which are very, very particular and very strong about your teaching, that is, don't use unnecessarily antibiotics, especially the 3rd generation. and the cleanliness, which is the 5 cleans, that how we started and brought down everything down, and we have to go back to our same old simple methods. And that was simply mind-blowing. I would now keep it open for the any question and answer. If any, Dr. Bharati, you can continue.
Yes, thank you, Dr. Muralidhar, and Madam Dr. Sareena. I have no words to express what an excellent way you took us through the preventive modalities which we need to follow. Very simple tips, just plain soap and water, just cleaning our labor rooms, using a glove, preventing infection by clipping the hair, and such small tips which can be maintained and taken up even in the smallest of centers with the basic needs, basic facilities. And the way you took us through the sofa, the quick sofa, and then the SAP score, and then the ABG was the last feather in the cap, which went with this and this, and now I think that's this for you. I have no other words to express, ma'am. It was an excellent lecture, and I'm sure all the participants will never ever have confusion about respiratory alkalosis or metabolic acidosis. I think we will always remember you when we start managing our sepsis cases. And sure, none of us want to have sepsis, so let's take more of a preventive protocol rather than having a patient of sepsis on our hands. And I thank you, madam, for being with us and spending your valuable time with us. The screen is open. We have our Chief Patron, Dr. M.G. Hiramat. I'm sure he's going to have excellent reviews for your talk.
Thank you, Bharati. Madam, wonderful talk, almost 45 minutes. I think you utilized your time fully. Normally, we keep these talks for 45 minutes. Madam, you have so nicely covered this topic, which is a very, very essential topic today. Because what is our aim is that we want to control the mortality. And one of the leading cause of mortality is sepsis. I think unless somebody deals the management of sepsis so methodically, then only you will be able to see that no woman will die either during pregnancy or during a gynecological operation. You have elaborately covered all the clinical aspects, how to diagnose, what are the aids you must take in diagnosis, role of ultrasound, role of CT, and role of MRI. Nowadays, we do use MRI a lot because the ultrasound diagnosis are not so 100% correct. Sometimes you are in doubt because you read the sonologist report, they write both way, maybe, may not be. Now that cannot be there. Today, with availability of CT and MRI, we must have a definitive diagnosis so that you can plan whether I must go for a conservative management or whether I should intervene. The decision to do surgery is very important because in these cases, the surgery is not a difficult one. Surgery is very simple. As you rightly told, remove the pus. And if you remove the infection site, almost they are normal. So if you delay in doing a surgery, you are going to lose the patient because infection will extend from grade 1 to grade 2, grade 3, and grade 4. And once the infection goes to grade 3 and grade 4, whatever procedure you do, you are likely to lose the patient. It may not be the death, or there may be a morbidity also. And you have beautifully covered on that. Fluid management also you have beautifully covered. Which fluid to be used, much fluid to be used. And nowadays we have got better monitoring for the fluids. And input and output chart is very, very important. Unless you see the input and output chart every day, you will not be knowing. Sometimes you give too much of fluid in a case where the fluid has to be restricted. Sometimes you don't give the fluid and patient will be dehydrated. I think input and output chart is very, very important, which is to be monitored. And you have covered all that SOFA, the Q SOFA, everything which are the newer aspects. And elaborately you have given an antibiotic knowledge. I think this should have come from a pharmacologist. And pharmacologists will dissect the drug and tell you what are its advantages and disadvantages. You have rightly said how to use the drugs, which are the drugs to be used, and which are the drugs not to be used, and to be used very, very carefully. And We have got in our hospital, where we have got our medical college hospital, it's a super specialty hospital of 400 bed. We have got a antibiotic protocol, and this antibiotic protocol is distributed to all the departments. They must use the protocol because drugs patient has to purchase from our pharmacy. And if it has come from an orthopedic department, the pharmacist will open the protocol and pharmacist will give him a feedback. Sir, your protocol number 1 is this drug. Why you have written to your patient this drug? That's how misuse of antibiotic is very much covered. And sepsis also is nowadays, there are institute, including our institute, where we have got a committee. This committee of review of the sepsis will be meeting every week. And this is headed by a professor of microbiology. A professor of microbiology with their team, they do the review of all these infections. I think if these all measures are taken, definitely the infection can be controlled and infection can be prevented, and women can have a safe delivery and they can have a safe surgery. Today, nobody will accept a death. Not only death, today nobody will accept a morbidity also. So when they are going out of the hospital, they should go as if when they have entered normally, when as in the same thing they want to go. I think your talk has given us an eyesight how exactly we can manage. And being a teacher, there is no problem for you to explain beautifully by raising your fingers up and down, because that is a very complicated, the metabolism. The metabolic understanding is so difficult, and you have made it so simple. I think if everybody follows this, it will be just very nice. On behalf of KCOG whole team, Dr. Vidya Thobi has joined, our president-elect, and the president going to be taken over, Dr. Kasturi, our president, Dr. Sajjan, all have joined here. All seniors faculties have joined just to listen to you. What is the protocol in your hospital? Because your hospital has got a very big name, particularly from the Kerala. Your mission hospital is one of the hospital where we always look at it, that what they are doing, particularly as told by our chairman, Dr. Pai, the auditing of the mortality. I think that has become the standard. We all follow that auditing. You being a member of that audit committee, definitely you have seen all these problems. That's how you have simplified the whole talk in a very simple way. Thank you very much, madam. Thank you and namaste for accepting our invitation and joining with us. We want you to come again and again, because our whole aim of KCOG and KCOG is to train our postgraduates. And training of the postgraduates, this is one way, because postgraduates are so busy in the ward, they are so busy in their day-to-day work. I think the evening at 7:30, they are very, very leisure. They can sit in their room hostel, they can sit in their house, and they can listen to you directly as if you are in the room only. This technology of Zoom has made learning so much, and we have learned many lessons in COVID. One of the lessons what you have learned is that Zoom technology is one of the best technology to learn in a leisurely time. Thank you very much, madam. Aarti, any vote of
Sir, I
thanks?
think there is a question from Dr.
Yeah,
Rahul.
take up.
Dr. Rahul Jadhav wants to know, he has congratulated you, madam. There are a lot of appreciative messages. And he wants to know, how do you monitor WBC and CRP post-cesarean, and what would be the reference values?
Okay, very good. It's a very good question. Now, in the presence of severe sepsis, there is no range. Now, let me tell you that I've got a case, on this case which I projected first. Before surgery, her total count was 28,000. After surgery, next day when I repeat it, it has dropped down to 20,000. That itself tells you a lot. Then the third day, it has dropped down to 18,000. It tells you a lot. So there is no range. We all know the normal ranges, but in the presence of severe sepsis, a dropping WBC count tells you that she's responding. That is why I said a WBC is what you can do every day. Now a CRP, the normal value is less than 0.6. Now we say that more than 6 you should give significance to. Forget about the same way WBC. Supposing I've got a CRP of 34, it is so high. But after I did that obstetric hysterectomy, the CRP has dropped to 25. She's responding. And then the third day when I see it has come, the CRP has come down to 20. I don't expect it to come back to 0.6. dropping, just look at the trend. That is your management of sepsis. Okay. So you must have a baseline. That's why I said the first 24 hours, I told you the SAPS 2. You do those initial simple investigations. Don't go for fantastic do simple blood culture, lactate, procalcitonin, whatever you do, just the CRP and the WBC. Do the electrolytes with the LFT, RFT, and the blood cultures. Only in severe sepsis, when you get a critical person involved, when you do the ABT. So the rest of the things you can do, and then you keep monitoring. You can also, then you would take, that's another, supposing you take for blood culture, and now you started around, say, cephalosporin sulbactam, okay? And then when the report comes, it says that it is sensitive to another antibiotic. But what has happened to your patient? She is better now. After you started the cephalosporin sulbactam, she's improving. No, don't go and change because your culture report came like that. Don't. The clinical parameters are so important. You're a clinician first. If she's responding, give the 5 days of cephalosporin because she's responding. But in case, again, the temperature starts hiking, then, of course, you change over according to the culture. Or the counts have started increasing or it started increasing, then you change it. If she's not improving, do you understand? So that is all. There is no hard and fast values in all these things. Just see the trend. The upward trend, that means she's worsening. Downward trend, she's improving.
Thank you, madam, for that very explicit answer, which you have told. Just a downward trend will tell us. And of course, very often we see clinicians changing antibiotics too frequently, just going on the culture values rather than the clinical improvement in the patient. I think we need to take the clinical signs as signs of improvement. I think that's a very good tip you have given here. If there are any questions, the screen is open. Otherwise, I think we should, we are running ahead of time and we are running late by 10 minutes. So I think we shall propose the vote of thanks. I request Dr. Manjula Patil, if she is there, to kindly propose the vote of thanks. Manjula, are you there? Okay, fine. Anyway, on behalf of KSOGA and KCOG, we have no words to express how happy we are here today to have Dr. Sareena talk to us on a very important topic of managing sepsis the optimum way. We thank you, madam, for your presence and look forward to being associated with you in many more such sessions. And we thank our chief patron, Dr. M.G. Hiremat, who is always there, much ahead of time and always there till the end of the program, giving his valuable inputs. You're our inspiration, sir, and we follow you. I thank Dr. Vidya Thobi, the President-elect of Karnataka State OG Association, for being with us here today and looking forward to have many more programs like this. I thank Dr. Muralidhar Pai, who has been instrumental, the Dean of he is the Chairman of KCOG, and he has been instrumental in bringing you here on this very important panel today. We thank Dr. Muralidhar Pai for the same. And I thank all our office bearers, thank all the delegates for being here and taking part in this webinar, and of course taking home many useful tips so that our clinical practice is more safe and our patients are also safe. We can prevent sepsis. So I thank all of you and wishing you a happy weekend. Goodbye and good night.
Goodbye. Namaste.
Thank you, sir.
Good
Namaste.
night.
Namaste.
Namaste.
Thank you, everyone.
Thank you, Dr. Vidya Thobi.
Thank you.
Namaste, madam, and thank you.